Good evening. Welcome. This is our third Oracle of Eye Innovation. And today it's a fantastic pleasure because starting off from the anterior part of the eye at the first one, working towards applications around the middle part of the eye, it's today a great pleasure to go towards the posterior part of the eye with fantastic speakers. And it's a great pleasure that they will share with us their perspective on, what is the innovation technology that they want to get in their hands in the near future. The intent of our little webinar is really kind of share amongst colleagues and friends, what is it, what is coming in our field in the different disciplines that excites clinicians from various perspectives. And sharing that is kind of what we are intending here, is to get a perspective, to understand where the clinician is coming from and why is he desperate to have this technology in his hands, and how it impacts and benefits patients or the life of a clinician. To do so, we requested the speakers to explain why this innovation excites them. Second, how they think it will change the life of a clinician. And of course, how it will change the life of our patients. And how does the innovation actually solve the problem? So how the technology will help, how will the innovation addresses a specific problem in ophthalmology and will solve it. By saying so, I'm very happy to introduce our first of all, Professor Kilic from Istanbul. She will introduce and address the single speakers. And I would like to thank Chris for helping in organizing, putting this together, and bringing this fantastic speakers tonight together to have a great discussion. And I'm really looking forward to sharing innovation, sharing ideas, and challenging with good discussion. Okay, so our first speaker will be Dr. Larsen from Denmark. And Michael, would you share your presentation? I can stop.
I will be talking. Maybe you want to enlarge me. So the insight that I have chosen to communicate here is what I see as a new mega trend in ophthalmology, and it is the accessibility, a whole new kind of accessibility of fundus imaging and fundus examination. And it is very strong in Denmark because the new technology of digital fundus imaging coupled with OCT and the portability of the image information has happened in a very interesting way, not through the public healthcare system, but because the optometrists have chosen to make fundus imaging available as either something you pay a nominal fee for or get absolutely for free, just as a way of attracting people to go in and visit an optometrist or optician, as they're usually in Denmark, who has the agenda of selling contact lenses or spectacles, and they're using a bait in the form of a so-called healthcare check. And this health checkup consists of a fundus imaging session. And they are imaging thousands of people every day. And obviously they're seeing a lot of healthy people who don't really need that. But we as ophthalmologists don't have the burden of seeing them because it's being taken care of outside the public healthcare system, completely on a free market base. And then we get a whole new kind of referrals We are seeing patients who come in with very early signs of Stargardt's disease with absolutely no detectable or symptomatic functional deficit, but they have the lesions. We make the phenotype classification, and mostly we do a molecular genetic and diagnosis as well. So we are collecting patients and keeping them in our registries, available for clinical trials and all kinds of family workups as relevant. And I think it's a new beginning for retinal disease and an opportunity to address issues potentially as new therapies pop up at a stage where there is still a lot to salvage. It's a fundamental problem in retinal disease that people come in very late with advanced retinitis pigmentosa, for instance, before they are diagnosed with that very serious and disease, which is going to give them a disability. They may already have a serious one when they are being diagnosed. Obviously, this is a kind of screening that has not been organized from top down, and it's not systematic, but it's working. It's doing something that has never been done before. And why can it happen? Because people have access to walk-in service. You don't have to make an appointment. You can do it on a whim as you walk down the high street. You see yourself in front of the optometrist shops, and they'll be waiting for you, not like having to book an appointment in our public healthcare system, which can be quite a nuisance. So even if you have a manifest vision problem, you will often be told you can appoint an appointment in 1 year from now, which is a problem that we have been unable to solve, although we've been very aware of it for 50 years or more. And now there is a lot of variation between countries, but I think it's coming to every country. Optometrists and opticians have very different levels of authorization, high levels in the English-speaking countries, and in, as I've heard, France and Turkey, there's very little they can do. They cannot even write a spectacle prescription. But I think it's going to be harmonized through market competition in the long run. And finally, people have found out that the internet exists and that referrals can have a fundus image attached. It's taken an incredibly long time for the public healthcare system to find out, but it is getting better. And I think there's also a possibility for an opening here, namely in the form of electronic patient records in the sky that are patients' personal property, so that they can easily move them around between providers. Something that our healthcare system doesn't offer, but I think it's going to be more democratically available in the future. So I think that this new megatrend of accessibility of fundus imaging, quasi-universal accessibility, it solves a problem by the means of accessibility, and it makes taxpayers customers rather than just cattle that you can herd around, can be herded around by public healthcare administrators, and it will make clinicians see more relevant patients earlier, and lots of irrelevant referrals will be filtered away. Some of this is already being handled by artificial intelligence, sorting algorithms. It excites me because it's a new kind of dynamics that has been introduced, and it's democratic without being too socialistic. And so that is my new mega trend on the radar, I believe, that I think it was worth communicating to you about in this exciting new forum of oracles. Thank you.
Thank you. Michael, I guess the development of imaging and the distribution of high-tech imaging devices to optometric outlets in many countries is beginning to revolutionize primary care. And I think that was one of the points you were making. I think it's going to be interesting to hear later, because that trend needs to be coupled with machine diagnosis. And when we have distribution of devices, we have changes in primary care, and we have machine diagnosis, that really opens up the optometrists in a big way. But I'm sure Adnan will say something about that later. Questions, please. Adnan. We
You're
can't
on
hear
mute,
you.
Adnan.
Can't hear you.
You're on mute. Yeah.
Oh, yes, try that. Hear me now?
Better.
Great, thanks. So Michael, wonderful insights. Just to share some UK experience, my cousins north of the border in Scotland have formalised optometrists to do primary care ophthalmology screening, as it's quite a sparse population. They've actually funded them to have OCTs, have put them on the secure NHS net system so they can refer with images. They haven't yet got AI, but they are really a model that the rest of the UK wish to follow, and in some ways the sort of model you're describing. So we're quite encouraged by the way that Scotland has already developed this, and we hope we can kind of go in that same direction. As you said, it's going to be very complementary to the way we manage our patients.
I guess maybe I'd like also to make a comment. It's I think it's a very nice vision, and it's a good use of optometry, particularly since there are such a long waiting list with a lot of people. There are other people, physicians, that could also benefit from this type of installation. When I was still in the Netherlands, we were toying with the idea of placing some cameras in large diabetic practices, you know, with the internist. Since, you know, otherwise we end up very often seeing a lot of patients that have no diabetic retinopathy, and the ones we want to see are the ones that require care. So optometry is a great idea, but maybe we should even expand this idea further to be able to place it elsewhere. And I like one of the points that came through my head, and Adnan, you've answered it in part, is how do we make sure that images can be transferred from optometry, from you know, from an internal medicine practice to us in a secure way? And how do we provide back diagnoses to people that are, you know, have come by an optometrist, and they may or may not be told, listen, I'm going to send this image off to an ophthalmologist, we'll get the diagnosis back and you're set. And so, you know, there are certain other aspects I think we have to also look at.
Especially with the recent changes in protection of individuals' data.
Absolutely, in Europe, yes, for sure, yes.
Adnan?
I think this process has been accelerating with the current pandemic. Patients have been fearful of coming to attend, you know, places like Moorfields is in the centre of London. You have to go through the tube system. And so we've started experimenting with shared care protocols where patients with, you know, diabetic macular edema, which need recurrent injections, you could possibly have an OCT scan at a regional optometric center and then only come up for a defined treatment. So I think the current pandemic will accelerate the sort of ideas that Michael is suggesting out of necessity.
Just would also like to add, some years ago when we developed a small handheld scanning laser ophthalmoscope, we took it into one of the Indian temples in London. And this is a population that really do not like to go to see doctors. And it was extraordinary within the temple to pick up really advanced cases of diabetic retinopathy, which normally wouldn't have been seen. So I think technology is developing now to the level where it's becoming much, much less expensive. And yeah, we have to address other problems, machine diagnosis, confidentiality of records, etc. But Michael, I think you've highlighted something that lots of us are moving towards, and I think it's a great movement, and really to be worked on by all of us.
Michael, may I ask you something? You mentioned that we might move the point of screening into the optician. You know, if you listen to the big companies like Google, Facebook, and those guys, they think a step ahead. They think we know everything about our customers and our population. Why are we not the future healthcare providers? What is your thought on that? So going even beyond what you mentioned, going from an ophthalmologist office to an optician, going beyond and going directly to consumers.
I'm sure that they have plans. They have developed algorithms and service systems, and they're waiting for change in attitude and legislation. But it is absurd that people are still being allowed to administer their own bank accounts when they cannot be allowed to administer their own health records. So it is legally in most countries your own personal property. There's a copy of it that's being managed by the healthcare providers, but it's your legal property. And why shouldn't your bank take care of it, for instance?
Michael, to that end, I've been involved recently. The British government wants a biometric in relation to all financial transactions, whether these on the web or cash machines or whatever. And we've been working on this as a consortium. And clearly the spin-off from this is detecting eye diseases, because the biometric is going to be eye-based. COVID has sort of cut off half the face, so facial analysis is difficult. Nobody wants to leave fingerprints. So it's going to be eye-based. And that is something that's really puzzling us at the moment. If we develop a system which recognizes you as an individual to a level that your banks and credit card companies are happy to deal with it, how do we deal with the problems when there is an aberrant and you're refused access because of changes in your retina or whatever? And it's going to be a big problem, but people are already addressing it, not the least of which are the lawyers.
Well, I see another problem potentially is that if you now use the retina and retinal features as a biometric, if you now exchange an image to get an opinion on some type of retinal pathology, obviously it could recognize the individual. That brings up other issues.
Yep.
But to get back to what you mentioned, biometrics, at least at the level of the iris, have been used in Amsterdam airport for quite a while. Yep. The way they've tried to get around it, because if you get eye pathology, you get cataract surgery or something else, it might change things, is that should you have surgery, you have to go back, and every 2 years, the biometrics have to be redone. So there may be ways around that aspect, but I had heard somebody talk about the fact that, yes, you know, they can recognize you on your retinal image, and now you're starting to make me a little bit more concerned.
Well, no, we in the early system, it called up the patient notes. So when the patient sat in front of the slit lamp, bang, you had the patient notes there, because the system was really very good.
Thank you. To some extent, the previous discussion has set the scene perfectly for my talk. Artificial intelligence, we cannot avoid this in every headline, and it generates both excitement and fear that it will take away our jobs as ophthalmologists or be intrusive about our personal lives. And just to remind us all about some basic definitions, so artificial intelligence, very old definition from the 40s of developing machines that mimic the way that humans think. And there are subgroups of artificial intelligence, machine learning, which is where you have an algorithm that modifies the way it works without explicitly being programmed. So example, you give it more data, it alters the way it thinks, you're not actually personally rewriting the code. And a subset of machine learning that's grabbing all the headlines is deep learning, that is a machine learning algorithm, but has a specific structure called a multi-layered neural network and specific ways of training that makes it exquisitely good at image recognition, which as a retina specialist is incredibly important. And where are we now, and why am I so excited at it? Despite all the hype, this is really delivering. And in fact, small aspects of it are already in clinical practice. And as we've heard from the previous discussion, will clearly impact our daily practices increasingly in the foreseeable future. And this is an editorial we wrote in Ophthalmology that summarizes a lot of the points I'm going to make. So there are already machine learning algorithms for biometry, the Hill RBF formula, visual field analysis, although they're not sort of FDA approved. There's lots of algorithms that look at optic nerve cupping, progression of visual fields, and I'm going to concentrate on really the retinal features in my talk. And there are all sorts of applications, from preclinical imaging to development of biomarkers, diabetic screening, which is really where we're already at clinical deployment, to how you manage patients in the real world in busy clinics. And I've been interested in this area since really the late 90s, when I was a resident doing research in the States with looking at the inundation of cytomegalovirus retinitis in the AIDS era, and we wanted to detect this and screen for it. And I worked with Caltech students to get some reasonably good algorithms that did that. And to date, what we're really doing with AI machine learning algorithms are to detect things that we can already detect. So drusen diabetic features. And I'm going to go into the end of the talk some examples of AI detecting things that we as ophthalmologists can't see. So where we are already, and what really excites me, is that this problem of mass screening of diabetes, we're very fortunate in the UK that we've had screening not by optometrists, not by ophthalmologists, by technicians that are trained to detect, look at the pictures of our diabetic patients every year, our 2 million diabetics, which averages at 10 million images a year, which is a huge burden even in the UK system. And if you've got 100 million in diabetics in India and China, that's 500 million images you have to read every year. And there are lots of algorithms that have gained a lot of press saying we can detect diabetic retinopathy, but how do we know they are good enough to deploy? And I'm just going to give you the premise of why it's important to understand the flaws and why we need to test these things independently. So a very simple example of machine learning algorithm is regression analysis. So this is something we all learned at medical school. So an example, if you want to compare the number of hemorrhages in a photo to the area of ischemia, you can plot out different pairs of images and then draw a line. And then you can put a new picture with a number of hemorrhages and try and predict the area of ischemia. But instead of plotting a line, you can join all your data up with a lovely squiggly line, which matches your data beautifully, but is very poorly predictive. And this is the example of overfitting. And this is some of the flaws in the early facial recognition algorithms, where it was trained on white males and did brilliantly on white males because it fitted the data of white males that it was trained with beautifully. But as soon as you put it at other racial genders, it performed pretty poorly. So it's very important you understand how you train these algorithms and how generalizable they are. This is something called overfitting of your data. And then you say, well, how good is it? And you can say it's as good as humans. What sort of humans? Untrained humans? Ophthalmologists? A group of ophthalmologists? Because we disagree. So when you look at these papers, it's not just about the algorithm, the generalizability, as what you're comparing it against. So one of the things I've been very interested in is how we independently validate these things. And clearly diabetes is the biggest challenge. And we were fortunate to get an NHS government grant a few years ago to look at all available CE marked algorithms and look at an adequately powered study and cost effectiveness for these algorithms. So we powered the study. You needed 20,000 consecutive patients to feel confident that the results were true. We looked at multiple different cameras, photographers, graders, and a very good spectrum of ethnicity and real world data patients had cataracts, other pathologies. And we've published this and shown that 2 of these algorithms, even these older algorithms, were at least as good as trained human graders, would save the NHS 10 to 15 million pounds a year, and even these older algorithms process about 600,000 images a day on cloud-based systems. So they are now, some of these are both CE marked, FDA approved, and we are in the implementation stage. We hope, COVID notwithstanding, of implementing this in the diabetic screening systems in the UK. We're looking at how these systems also work on wide field imaging, which may actually give us even better results. Can we leave it to the regulators? The FDA just do studies on 700 or 800 patients. Ours was 20,000, because even if an algorithm detects all proliferative disease on 800 cases, your confidence intervals are huge. But the FDA say, well, actually, we may not even need to do that. We can trust Google or IBM or these big companies to test themselves. But we've seen with recent aircraft disasters that may not be a good thing. So I'm very passionate about how great these algorithms is, but they need vigorous independent testing. I'm now just going to briefly talk about biomarkers. The other area of interest is developing algorithms that will actually detect features for both population studies and our patients in our clinic. So biomarkers can be trained to look at specific features or have sparse detection, such as AMD. So you can have an algorithm that we can say has a label, it will detect AMD or not, but what's it looking at? And this is some lovely work from Aaron Lee, where he masked the image and showed the deep learning algorithm picked these bright areas, differentiating a normal from AMD. We've looked at this now, there's some nice work from Praveen Patel, where they've segmented the RPE and shown that in the UK biobank study of 80,000 patients, how RPE Brooks membrane changes change with age and race. So these great algorithms are not just useful for our clinical patients detecting diabetes, but are going to be really important research when we start getting large data sets. We can also segment choroids, this work from Peter Malocca's group in Switzerland. And this is some really pivotal work from the Moorfields DeepMind group, led by my colleague Piers Keane on the clinical side, and the great programs from DeepMind, where in this this sort of baseline study, we can detect key features that will help triage patients to whether they need to be referred urgently to optometrists or not. This needs further validation work, but just shows the principle. So further work is needed before clinical deployment. And Ursula's group has now developed some quantitative aspects to such algorithms. So my interest is really understanding AMD more, and this is part of a grant we're doing, and Roy Schwartz is leading on, is presenting at URetina next week, where we can detect reticular pseudodrusen, even on old first generation OCTs. And we're trying to bring it all together, and this is work we've been doing now with University of Nijmegen for the last 2 years on very large EMR OCT data sets. We're not just quantifying all the key features of wet AMD, we're now picking up all the features of atrophic and dry AMD and quantifying each of those features and trying to put it all together. Again, this is work that's under review and is being presented at URetina by Bart next week. And this is an example of the output showing each of the key features, including atrophy, subretinal drusenoid deposits, ellipsoid zone loss, etc. And we think when you actually start applying this into clinical practice in busy injection clinics, in optometric practice, this will really enhance referral and reduce the burden on optometrists in busy injection practice. But what we'd love to do is unify this with home monitoring. And this is a device developed by Peter Malocca. It's a binocular OCT. The patient puts their face down on the little device. They hug around the device. And the top is an example of the OCT from this device that takes 2 seconds to scan both eyes. The bottom is a high-grade commercial OCT. And the idea is that the AI algorithms that we're developing will say, you need another injection, or you need another scan in a day or two, and then we'll alert you when you need a treatment. But can we go beyond what humans see? So what I've described so far is things that we see, but reduces the burden on us, or because the data volume is so large. We're now starting to develop algorithms that detect things we can't see. And this is some really pivotal work here from Aaron Lee's group, who was a fellow with us, who's now a professor at the University of Washington, Seattle, where he said, well, can we train, is there information on a structural OCT that may suggest flow? So he cross-trained structural OCT with angio-OCT. So there's no way on a structural OCT you could detect flow. It's a single static image. But there may be hidden information in an angio-OCT or a structural OCT that infers that flow may be there. And remarkably, that worked. And so this is an example of the structural OCT showing the small vessels. This is the OCTA, and this is the output of where the flow is inferred on a structural OCT. And we validated this looking at patients with capillary dropout vein occlusions to show you there is inferred information on a structural OCT that if you train it, you can pick that out. And we've now, his group has also done this with functional data, so inferred microperimetry data from a structural OCT. So this is some incredibly exciting thing, and we're now starting to go to the point beyond what we can see. But what excites me now is what we can do now, which is diabetic screening for all our patients at a cheap, deployable cost, and potential to integrate these exciting algorithms into our daily injection practices, our biometry, and our glaucoma detection. There's almost too much to talk about. It's such an exciting area. So I'll stop there. Thank you.
Thank you so much, Adnan. It is really, really a wonderful presentation, and it will be future, looks like maybe for all other ophthalmology area or other medical area. My question is, would you trust 100% artificial intelligence for screening diabetes if it will be the even highest level, the best level? Would you trust according to this? Would you treat?
So that's a really interesting question. So one of the things is, what are we comparing it against? And that's human graders. Human graders have an error rate. We don't admit we have an error rate, but there's plenty of data showing that we miss even proliferative disease. Our agreement on things like ERMAs is about, the kappa is about 0.3. And we have in the UK very good data on what our error rate is. We have shown these algorithms are as good and as human graders, and these are human graders cross-checked with the Tahini Reading Center, and unlike us, don't get tired. We have developed very tight confidence intervals, and on the recent study we did on the new algorithms on 30,000 patients in 3 centers in the UK, it did not miss a single proliferative or severe non-proliferative diabetic retinopathy. It missed the odd maculopathy, which in screening terms is not going to massively affect patient outcomes. So yes, I do in this, and I would say I'd actually trust it more than probably screening at passport control, because at least we have open data on how good these are. I'm not quite sure how good the screening at passport control is. So, but we are there, but we really need to know the error rate and be honest about it. And it's as good as us.
I think that's an important point, is that as long as it's open data and we know what the error rates are and what the error sources are, it's fine. But if it gets, you know, a commercial business for a few tech companies, that's where I would get worried, because then maybe we don't know what the error rate is or the reason for it. So what do you think? I
completely agree. And this is what the white paper from the FDA that says maybe the big tech companies know enough to police themselves, given the FAA debacle with Boeing, makes me very worried. And I think, so we're moving towards, at least with the NHS, rigorous independent evaluation before deployment on the NHS. CE marking and FDA approval are not enough of a good enough standard for clinical deployability yet.
If anything, I think we need to develop a new standard that would establish what we require from these companies or from these new. And I think, you know, you've identified very nicely where we are, what is required, how you have to watch out for having, you know, data that is being over-analyzed. I think those are extremely good points.
Michael.
An interesting aspect that we have looked at, or an insight that we found when we were doing population studies, is that, for instance, if you look at glaucoma prediction models, as they're available on some OCT volume scan devices, they have a difficulty identifying not disease, but normality. So they produce a lot of false positive, a lot of false glaucoma warnings. And if your data is based on patient populations, then you're biased towards detecting abnormalities. If you want to deploy something in an optometry shop, it should be population-based so that you have a proper weight of normality.
So I think your point's incredibly well made. So what happens in the early papers on AI, they always produce what called ROC curves, which is all the possible cutoff points of sensitivity and specificity. What we need as clinicians is a fixed point. We don't think about different operating points. We have a blood test that is either normal or abnormal. And then we test how good that normal and abnormal is in the population of interest. And the reason we use AI is because it reduces the cost of us, and there's not enough of us. So then you need a health economics analysis with the risk of missing severe cases. You need to put all of that in, and as you said, that cutoff may be different in primary screening and optometrist and in an injection clinic with a retina specialist. So all of that really needs to be built in. That's really well highlighted, Michael.
There's one other issue, Adnan, and that is, and we found this in sort of looking for the norm, as it were, and that is the differences between images from devices from different manufacturers. So if you're not careful, you end up with a gold standard for each of these companies. And I think what you're aiming at is a consolidated gold standard across the board.
So we're fortunate, so in the UK has defined camera types for diabetic screening. So it's not one, there's multiple different camera types, but they have a certain pixel resolution and certain type of camera back. So we tested on all of those. So you still need standards because different cameras have different pickup rates, even with humans, on detection of diabetic features. So you need to standardize what we can see anyway, and then make sure those systems work on everything. And if you change the camera system in the future, you need to validate it again, potentially with that change. And that's built into the sort of work we're doing to make sure we future-proof it as the systems change and the imaging systems change.
Device dependence is a big problem in corneal photography, for example.
Bill, well, I was going to say, Bill Trattler, do you want to make any comments from your perspective regarding AI and use in terms of corneal diagnostics? You're muted.
Mute.
Sorry. Unmute. There you go.
Sorry about that. Obviously, in the cornea field, a lot of companies are working on technologies to automate topography interpretation. Obviously, we talk about glaucoma. I think retina is much further along than the anterior segment, and I love all your work. Thank you.
I think it's a great, I mean, anterior segment is ripe for this, as you said, corneal topography especially. Biometry is already there with kind of the Hill RBF. And I'm sure as we get pool massive refractive data outcomes, I think that will be great. You need the data, but it's kind of getting there. And when it's starting to get pooled, then I think, you know, people can go in and really get some great stuff out of that. Very exciting.
Yeah, but as a refractive surgeon also, I would like to make a comment to Chris' question. I need to see patients. Because we are not treating disease, we are changing life quality of patients. this is a little bit different than retina, because I need to see patient, how is his mood, if he is type A personality, if he is suitable, if it is easygoing. I need to talk, I need to see relatives sometimes, even their clothes, their behavior, their reaction gives me some clue. This is not only topography, and not make a decision just with topography. It is impossible in refractive surgery. I always need to see patients. This is at the moment my feeling. Maybe in future there will be special artificial intelligence to give me report about his mood, his heart beating, or his excitement, maybe something like that. So hopefully.
I'm sure there will be, but that's why I stick to retina and keep away from refractive surgery. I leave it to you guys.
Yeah.
Wise decision, I agree.
So I don't want to interrupt, but this is really wonderful discussion, but we need to move. Third speaker, Marc De Smet, he will talk about retinal surgery robotics. Thank you so much, Marc.
Thank you. Let's see if I can get this started here. Are you able to see my first slide?
Yeah.
Okay, perfect. So yeah, the topic I'm going to talk to you about is robotics in ocular surgery. And I've been working on this for quite a few years now, probably about close to 14. So you've already heard from Adnan that people are worried about the fact that robots are going to take over jobs. And robots have been part of our lives for a very long time. I mean, in terms of industrial robots, they've been around since about the 1980s. And they've taken over large parts of heavy industry and areas where there is a risk associated with humans. We also accept them usually quite easily when it is used to be an assistive device, where it helps with cognitive development, providing you with body support or prosthesis if you require them. And it's also used for telepresence. And in all of these applications, they in fact enhance our abilities without essentially trying to replace them. Now, with regards to surgery, it's been around since about 2020. And the first such robot really that has dominated the market was the Da Vinci robot. It's a massive device which is used essentially for abdominal surgery and a lot less with, it has been tried for ophthalmic microsurgery, but if you look at its massive size, it's not necessarily adapted to our specific use. So coming back to the questions that were asked is, does this technology solve a problem, and in particular for ophthalmology? Well, there are several problems, one of which I've just indicated to you is the size of the device. And what we need is something that is non-intrusive, which fits essentially in existing ORs rather than having to build a new one. Something which, in my opinion, is important is where the surgeon remains in control and doesn't give everything over back to a robotic system, so that we don't end up with a Boeing 7 MAX 8. You want something that the surgeon can use for assigned tasks in a controlled, standardized fashion, where he essentially becomes better than what he's able to do today. So looking at vitreoretinal surgery, this is the device that we've tried to make, is something that is called a telerobot. Whatever happens inside the eye is being directed by a manipulator on the right side. And for the first time in a surgeon's life, you're not operating at a distance, you're operating at the tip of the instrument. And I think even for an anterior segment surgeon, can you imagine being able to work your phaco machine inside the eye instead of being outside? And this is the feel that you get from this. In addition to a lot of other features, for example, if you place a bound, you'll be unable to cause any retinal damage, as we've demonstrated here in a simulation performed in your retina in 2018. At the same time, using training simulators, it does show that time is somewhat longer, but you do avoid the injuries that I've mentioned. And there are features that are in there, for example, freeze functionalities, the fact that you have a bound, an audio function that tells you when you're getting closer to the retinal surface. And you'll notice that there's a difference in acceptability, or the idea of feeling safe. And beginning surgeons, novice surgeons usually like all of these features, and somebody who's experienced, a key opinion leader, doesn't feel that it's necessary. And indeed, I don't like the idea, even though I've developed this, and when I use this robot, that it takes more time. I can do things faster manually, and I've developed the techniques that I need to do it. But there are certain things that, for example, if we're starting to look at subretinal injections, and we have here a simulation that we've created, again, for Euretina this past year, you'll see the difference on the right side between manual versus robotic. There's a lot more jitteriness and movement. This has to do with our own tremor. So as we're trying to inject in this model under a sheet of paper, you are able to create a bleb using the robotic system, and it's much more difficult to do when it's done manually. And we show this here also from the ARVO poster, where we've used the Zeiss OCT microscope in a cadaver pig model, where we've added something so that we can see reflux. So bleb creation manually is more difficult. It was done in 40% of cases, but we weren't able to achieve the lack of leakage. So from our perspective, this isn't really we didn't achieve our goals, and this is true for most subretinal injections right now. All of them have reflux. In fact, even if you look at the Luxturna product that has been commercialized, there's an excess present there because we expect this. When you use the robot, we're able to create a bleb in 100% of cases. We still get some leakage. We need to work a little bit more on it. So we did achieve our goal in a large number of situations. How does this innovation solve the problem? Well, in part, I've just shown you some of the solutions. It has to do with the fact that it's intuitive, that we can provide positional stability. It's highly precise, and it filters tremor. And in terms of accuracy and precision, yes, if you let the robot carry out a task, for example, statically, it'll be able to maintain it at about 1 to 3 microns. If it's able to drive a given motion by using a visualization system, it will remain in that same type of area, while we ourselves reduce the precision of a robot down to about 30 to 100 microns in terms of precision. And that's despite using something to be able to attenuate tremor. So does it change the life of clinicians? Well, we've asked clinicians to try our system, and they've all said that it causes less strain. It's more restful in terms of position, causes less stress. And they've all started to think about new solutions, new things they could do with the robot that they weren't able to do before. And the 3 key features were motion stop, assisted in positioning, and task suspension. Task suspension being the fact that you can just look at what you're doing, potentially exchange an instrument, come back to the same spot without you having to give your instrument off to a nurse. You just continue thinking about what you need to do. And for a vitreoretinal surgeon, that's important. Here you can see the degree of filtering that can occur. When you filter, it's important that you don't get delays. So we only want to filter a certain degree of tremors, so something about 2 hertz, and as you can see, it does lead to an improvement. Does it change the life of patients? Well, we don't have data right now. We're just completing a study in Rotterdam where we'll get patient data with regards to their experience with the robot. However, quite a few have contacted Precise, and when we had the experiment going on in Oxford, the first clinical series, they were inundated with calls, and the first patient had to be delayed, and he absolutely wanted to be operated by the robot and was absolutely enchanted by it. So I think we're accepting more and more that, you know, robots can do things for us, and I don't think it's going to be a problem. I think for patients, they'll certainly be willing to accept it. Most likely in the same way as we accept flying in a plane today, where a pilot is still in the pilot's seat, but we know that if you're flying, it's really a computer that is flying the plane. The last question is not so much whether I'm excited with it, but why should this innovation not excite you? After all, here you are, you're operating, you have your device next to you, you have a critical task you want to carry out, or maybe you want to automate partially cataract surgery. So why wouldn't you want to use something that is able to take the jitteriness we have on the right side, bring it to what we have on the left, to less than 5 microns of motion, and be able to allow you to carry out tasks. In cataract surgery, for example, because we have such stability, we could go through a tiny incision, get through a tiny incision in the lens, and probably do a very, very precise lensectomy. And with regards to vitreoretinal surgery, I've shown you subretinal surgery. We can do epiretinal membrane peels. We can exchange fluid, even though we're not able to see the optic nerve. And I can go on and on, but I think I'll stop here.
Oh, this is really wonderful, Mark. Thank you so much. My question is, as a refractive surgeon, maybe all other attending people may not be a retinal surgeon. Which retinal diseases can be used this robotic surgery? I understood making injection, but which diseases? This is retinal, intraretinal, subretinal injection, whatever, intravitreal injection. Which diseases?
Well, for intravitreal, it's not so useful, although there is a device that has been developed in Zurich that would allow automated injections. The device itself has been sold to Chinese, from what I understand. So it's now Chinese technology and probably has a good place over there. The problem, and so we are developing it still. We've used it for injections in subretinal hemorrhages. We've done epiretinal membrane peels. We've looked at doing air fluid gas exchanges, and we're trying to optimize right now subretinal delivery because for gene therapy, given the fact that if you want it to be done correctly, you want to avoid an immune response, so you must not get into the choroid. And as much as possible, given the cost of development and of producing the product, you'd like to limit it just to the amount that needs to go into that space. So we're very close to that, although now we have a hurdle. We need to convince the drug companies that this is the way to go.
Okay, thank you so much. So is there any questions?
Yeah,
Adnan,
yes. So Mark, I can see for very expensive therapies and the tremor issue with doing a subretinal injection for even the best surgeon, it being an attractive way to go. But I'm just going to be slightly provocative to my cornea refractive guys. Femtophaco, with the head-to-head trials, which is kind of a robotic surgery, you could argue. It does a lot of your phaco for you. When it comes down to outcomes and cost effectiveness, has not really done as well as we'd hoped. What's your views on the future of robotics? In fact, John's another potential commenter on this. What do you think about robotics in the anterior segment?
So we've looked at it. We didn't get into it. You know, if you develop something, you have to focus. And in some ways, I was very happy when Femto came along because our development price right now is 500,000. So we're at the price of what Femto was being sold for. And Femto, initially, you had to get to a second table, use your Femto, bring the patient to the operating room table, and we've solved that to some extent. Plus, I think, you know, the future of any technology of this sort is it has to be usable in more than one area. So, yes, I think glaucoma would be easy. Putting in a shunt would be easy using this technology. Doing whatever Femto is doing, we could do equally well. We just need to have a port entry that is stable, and that's what we provide. So in some sense, yes, I think, you know, Femto, unfortunately, was a beautiful robotic technology, but it only did part of the cataract surgery. And it only could do that. It couldn't really do much else. Of course, John may contradict me on that, but that's my take on what Femto was. And yes, we still are looking at development, but we do have a product that could be used for a very specific application today. And cost of development goes down. If this is our start cost, everything else would be cheaper after.
Yeah. Now, Mark, I've been really surprised, actually, given the use of stereotactic design systems in brain surgery for many years. And given the fact that we have an almost spherical organ, which really lends itself to these sorts of procedures, it wouldn't be too difficult, I would have thought, to have robotic cataract extraction, for example. The issues here you yourself highlighted were, first of all, device cost, and then secondly, professional resistance. You know, in UK, nurses do a lot of injections for AMD, some resistance. Other countries would find that horrifying. What, nurses doing these injections? Really, goodness. And now we're moving into the era of robotics. So I think robotics have a huge future, especially coupled with machine learning, etc. But what we really have to do is to decide what the cost effectiveness is going to be and where will we meet professional resistance and where won't we, and where will it really improve the system? So I guess as someone that sort of developed and commercialized a number of devices, that's what I don't understand at present. I can't actually really put my hand on the market and say, that's where we're going to go, and that's where this system's really.
Well, I think it's, I could have gone to cataracts early on, and we didn't because it was a mature market. And yes, I expected more resistance, and retina made more sense because it's less predictive and there may be things we need to do.
Yeah.
But yes, cataract would be an interesting one. And well, the entry point in anything that has to do with anterior segment is obviously refractive.
Yes.
So, you know, you're going to look at premium lenses. My vision of the future is if you have a robot system that gets into the anterior segment, why the hell do we need to remove the capsule? Why not just remove the cortex, scrape whatever cells are on the interior surface of the anterior capsule, and inject an elastomer and give back to people their vision, you know, and their refraction, their accommodation when they were 20 years old.
Absolutely.
So,
Yeah.
you know, that may be, but one of the steps might just be perfect centration, using some devices that allow you to see the exact type of corneal aberration so that you get perfect centration. You place your lens inside the bag in a way that you could only dream of today, because with precision and stability, you can take your time. And that time may be just 30 seconds as it can be many minutes.
Yeah.
Yeah.
Well, and I think we should always appreciate the old saying, if you don't need a laser, don't use it.
Absolutely.
So there's another equation also that is coming along. And, you know, in Switzerland, we faced it about 2 years ago. The Minister of Health decided to cut all surgical, ophthalmic surgical fees by 70%. And so to tell you, this is not the rate we get because it's negotiated with all kinds of, clinics and everything else. But the official rate is 70 Swiss francs for a cataract right now. So, you know, it costs me more to get a haircut. So my wife does it now. But if that's a worldwide trend, you know, having a device that can do the surgery while you see patients and where you still have to dial in the specifics, a bit like when you do your refractive surgery, you know, it may become a way of the future. And because it's so miniaturized, you could do it in your office. You just need to have a little bit of laminar flow to keep it sterile. And I think in the future, we'll have systems in our offices and we'll be able to combine whatever we're doing, or otherwise a structure that is similar to when you started to introduce refractive surgery. So that's the same model. John.
Yeah. Now, I'm looking forward to board-certified robots in the US.
Yep.
Well, guys, I chose the subject tonight of AMD pathology or aging physiology and then mechanisms for early intervention. Sorry, could you go back?
I did.
Yeah, okay. And most people look at AMD, unfortunately, a lot of patients come in late when they've got a neovascular problem. And most of the emphasis in recent years has been on the genetics of AMD. Next. Sorry about this. Next slide. Okay, well, I think everybody should remember that it was 1953 that the classical Watson and Crick paper appeared in Nature. And 50 years later, we had the entire human genome and the Book of Man. Now, when you look at AMD, currently we've got 54 candidate genes at 34 different loci. So if we're going to be dependent in future upon gene therapy and personalized medicine, this is going to be a long job with 34 different loci and different effects of the genes. Next. gives you plenty of thinking time. I need a robotic changer. Okay, now the bit that tends to get ignored, but we all know, is the biggest risk factor in AMD is actually aging. So it would appear that what we actually see in the eye is a combination of, in many cases, a defective gene, but an underlying aging phenomena in the outer retina. Now, the retina is a very special case because we're dealing with aging plus stress, and the retina is the only part of the body where optical radiation penetrates inside the body. And not only does the optical radiation penetrate inside, but it has to be absorbed, and it's absorbed in both the photoreceptor cells and the retinal pigment epithelium. Next. Okay, well, everybody knows that photoreceptors develop this wonderful mechanism. The cells themselves can't divide, but they do remanufacture on a constant basis their light-sensitive discs containing a double membrane system with rhodopsin and, in the case of cones, other visual pigments. Now, this regenerative process in turn leads to problems during age. First of all, we see a build-up of lipofuscin in the retinal pigment epithelium, Kilic. Then we see a build-up of waste products within Bruch's membrane, Kilic. And unfortunately, in many individuals, this is sufficient that we see subretinal debris in the form of drusen, which displace the overlying pigment epithelium. So this process of clogging both the pigment epithelium and Bruch's membrane have serious consequences for visual function, in that all the transport properties through Bruch's membrane and the outer retina progressively decline with life. And we see an exponential decay of the ability of water to move out of the retina, but there is a linear decay of amino acid transport and carrier transplant port. So I had a very simple concept, and that was, as a function of aging, all cellular systems decline. They start very wonderful systems at 100%, and then as you get older, the function progressively declines. And if you're unlucky enough to have a defective gene, then the rate of decline may significantly increase. So I wondered if you could push up the basic aging curve and essentially rejuvenate the outer retina, you'd probably be dead before the combination of aging and the genetic defect led to significant visual loss. Now, this resulted in a huge number of papers from my group over the years. Next. So I'm not going to go into this in great detail, but there are getting on for 100 publications in which we've investigated this process. And it's clearly related to a progressive decline in the body's natural processes to degrade the deposits in Bruch's membrane and to clear the lipofuscin. Now, it turns out that on laser impacts, the pigment epithelium is caused to migrate and divide, and that releases MMPs in an active form, and they can clean the system up. So you can't use conventional laser because you destroy the photoreceptor cells, the very cells you're trying to preserve. And so we came up with a nanopulse laser, and most importantly, a discontinuous beam distribution. So the picture you see there, the dark areas are cells that have been raised above threshold, and the light areas are cells that have not been harmed in any way by the laser. So the good news about that is the dark cells result in production of metalloproteases to clean the system up, and the green cells sustain vision in the overlying photoreceptors. So if you hit a patient's eye with this, they have no perception that they have had a laser impact. Next slide. And again, a great deal of work went on to show that the impact actually caused changes which effectively rejuvenated transport in the outer retina. You can see there's an almost exponential increase in transport associated with MMP9. So this laser initially went to trial by our group at Moorfields with Peter Hamilton, and it was used initially to treat diabetic retinopathy because if it would improve transport, it should result in clearance of the subretinal fluid. And this was headed up by Lucia Pellicini and showed very clearly that this system was extremely effective in clearing macular edema in diabetics without any collateral retinal damage. Subsequently, next slide, the system was trialed for AMD, a multi-center trial by Robin Geimer in Australia, and the results were a little bit confusing until the retroanalysis showed why. Patients with classical drusen, i.e. beneath the retinal pigment epithelium, and that's what the laser was designed to cope with, showed a significant improvement and a significant delay in transfer between dry to wet AMD. By contrast, those individuals with pseudoreticular drusen, i.e. debris in front of the pigment epithelium, showed a worsening. So that was difficult, and some protagonists have said, oh, you shouldn't use it. My response immediately was, no, you should actually review patients going into these trials. So currently we're setting up a new trial under FDA guidance for a multi-center trial in the US, the SLAM trial, in which we will absolutely address the issues of where debris is. And I think Adnan showed very early on the beauty of modern imaging devices in giving us this ability to discriminate. So next, we have good cross-correlation with the production of MMPs and treating ocular conditions. Some of you will have followed the LIGHT trial. So the LIGHT trial for glaucoma, it took 20 years. I can remember our first experiments with SLT systems, which showed very significant changes, but the trial took 20 years to complete. Thank goodness it's here. Now recommendation that perhaps it's the first line of treatment for diabetics. To our T trial, the LEAD trial, 12 years from initiation of the laser system. Same mechanism, upregulation of MMPs, in this case, cleaning collagen in Bruch's membrane as opposed to collagen in trabecular meshwork. Hence, we are now really excited about the new SLAM trial with a more rigorously organized patient entrance requirements. Now, just think about this. Treatment for AMD, we're only treating between 7 and 10% with anti-VEGF treatments. Huge cost to the NHS, absolutely huge cost. So this laser would actually save an enormous amount of money if we can significantly reduce the conversion of dry to wet. And now we'd be dealing with 90% of the patients instead of less than 10%. Next slide. So finally, in response to Aylin's questions, what problem does the chosen technology solve? Its sight-threatening consequences of AMD. How does the innovation solve the problem? It removes aging in Bruch's membrane and rejuvenates transport processes. How does this innovation change the patients? Well, it reduces blinding consequences. How does this innovation change the life of the clinicians? Great, it puts the doctor back in control and reduces workload, don't have to do all those horrible injections. Why does this innovation excite me? Well, it's an interesting combination of saving site, saving clinical time, and saving money. Thank you. And thank you, Chris. Sorry about the delay.
This is really wonderful talk. Thank you so much. My question is, when it will be possible to use this technology, when we will able to see in the market or in our clinic earliest?
Well, the laser has undergone an ownership change. It was, I took my patents to a company called Alex in Australia. Alex has been sold to Quantel, but we retained the 2RT system, and now that's owned by Nova I R&D, which is a startup which is currently raising funds for the next trial. Alex did sell a number of systems, and they've been used in many countries throughout Europe. Unfortunately, a lot of individuals didn't stick to protocols, but hopefully, clinical trial, if this time we have a better entrance input, the FDA has agreed some interesting outcome criteria, and we're looking at probably 3 years from commencement of trial, which should be first quarter next year.
Wow, okay, thank you. Do you have any question from our panelists?
John, really
Adnan?
great talk, and hopefully as future trials, when you get rid of the reticular pseudodrusen, may show much more positive results. Just a sort of question that always comes up from the fellows and residents is, they get confused, micropulse versus your laser versus 670 nanometer rejuvenation.
Yeah, yeah.
Can you summarize that and what the pros and cons or the evidence base for
Okay,
those?
well, since the first use of lasers for retinal treatment in the late 60s, early 70s, those used millisecond pulses, which were actually designed to destroy ischemic retina. So the original design was to destroy all the layers of the neural retina. Then we thought, well, actually, if we could shift oxygen from the choroid to the retina by destroying the major oxygen consumer, the photoreceptors, that led to shorter pulses, and then the development of the microsecond pulses. But with microsecond lasers, you still have thermal spread into the photoreceptor cells, one, and because you destroy a plaque of cells or stimulate a plaque of cells, you switch off all the transport within the plaque. So cells will secondarily degenerate in that area. That's why we went to nanosecond with this discontinuous pulse duration. The later system, I'm not sure how that works. You know, I've been in the laser field for 50 years, and we had that discussion earlier about when you don't know what you're doing, do it neatly and say it with gravitas. So I don't know how that system works. I understand the others, and the reason why we've gone shorter and shorter and shorter is to limit collateral heat flow. And with the nanosecond pulse, there is no heat flow. It's all consolidated around the pigment granules. That discontinuous beam preserves photoreceptors. Who knows what tomorrow's innovation is, but I'm really excited about this one because it could save the NHS a lot of money and you a lot of time.
Maybe I'd like to
ask you. Is
ask
there any
you
question?
Yes, it's an interesting concept. I think that you destroy or tickle a few cells, and probably the others multiply and move in and produce maybe matrix metalloproteases that will sort of help with the extracellular matrix. But in general, in biology, if you do something like that, the effect is temporary. So is it just one treatment you're proposing, or a series of treatments that have to be repeated at a certain interval?
It's a good question. probably takes, well, it certainly takes 40 to 50 years to build up your debris. So it's a bit like hair in the plug hole of your shower. It builds up and you pull it out, whoosh, and everything goes back. So if it took 50 years to get there, you treat it and clean it up, it may take another 50 years to build up again. So that's the concept. It should be a one-off. And ideally, I'd like it to be prophylactic. I wish I could have had it when I was 40.
So then the other question is, you know, each person is different. So how do you titrate? It can't be sort of one size fits all.
Yeah, that's another issue. And what we've been working on most recently is titrating input number and dosage of MMP release. Now, ideally, the first sign here is changes, well, the first sign is changes in visual pigment concentration in the outer segments. The second sign is electrophysiology. Now, we're not suggesting for one moment that that's carried on into the clinic, but that should give us some indication as to effective dose in response within 3 to 6 weeks of irradiation. So that's what we're working on at the moment. And then it's going to be a question of personalizing, as you said.
Thank you so much. Now we should move next speaker if I have no disconnection. I'm happy to introduce William Trattler. He is refractive surgeon and he will talk about drops for correcting presbyopia. Our word is presbyopia. We are happy to introduce you all refractive surgeons. He will talk about drops to solve this problem. Thank you so much, Bill.
Great to see Bill talking about retina.
Yes. So I know this is like the extra little talk, but it's interesting because obviously the retina is critical to us seeing, but you know, some of the patients have difficulty seeing in different situations. So hopefully this talk will be helpful and inspiring and interesting. I feel very honored to be part of this illustrious group and sharing my thoughts on this topic. I do work with a lot of the companies, including Allergan, Novartis, Erasis, and Visus. I think, and everyone here on the call and all the listeners, everyone knows about presbyopia. You can see I have just the start of presbyopia. I'm in my 50s, so I'm a little bit further down in the curve. But I just started wearing these glasses the last year or so, just for the smaller print. And I can actually see my computer screen without glasses, but it's just crisper. At this point, if I just put this is a +1, just give me a little extra amount of reading. And it affects people, you know, in all different ages once you hit the presbyopic age group. We know it's age-related. It's very common. You can see it's, you know, the world population, presbyopia is a huge amount. And it's a significant unmet need because while there's lots of options, many of them involve surgery and or contacts, and we just need some more options that can help our patients. When we think about it, you know, this loss of range of vision can affect people differently. So we know our hyperopes, that hits them earlier. They become presbyopic and they can't read. I'm more of a mild myope, so that's why I'm in my 50s and just now starting to wear reading glasses. I also, like Dr. Kilic, perform lots of cataract surgery. And when we place monofocal lenses, they immediately become, in a sense, lose all their range of vision. They have no real options other than to wear contacts or glasses at that point. So there's really a wide number of patients that could benefit from therapies that can help with increasing their range of vision. Patients tell us every day, because again, as Dr. Kilic and I, Dr. Mrochen, we know we're refractive surgeons, and so you see these patients coming in frustrated with presbyopia. You know, it's worse when it's dark, so having bright lights help. They get headaches, eye strain, vision blur. Again, not as serious in some respects as the retina and what we're discussing today for the retina issues, but it affects our patients so commonly. It's such a widespread issue, which is why this is an important development. Let's just look at one patient. We've been doing refractive surgery for the last 20 to 25 years, and we're seeing now lots of patients that had LASIK in their 20s and 30s, and then they get into their 40s. The LASIK were great. They have great vision for distance, but now they can't read. And it's tough because, you know, they don't want to wear glasses anymore. They want to they don't want to return to glasses, but the surgical options in these cases are very not the best. We'll talk about the options, but having a therapy that they could use, like drops for presbyopia, may be quite helpful. And so, and that's like, I think a lot of patients are waiting for this technology. Here's another situation. There's a patient in their 40s that has a form of keratoconus. They have some degree of keratoconus, so they can't have LASIK, they can't have PRK. Refractive lens exchange, it's really tough to correct this. So having the ability to, one of the therapies would be to make the pupil smaller. It can really help this group of patients with keratoconus. Here's my list of surgical options. I bet I missed one or two options, but we know we have LASIK, SMILE, PRK. We have refractive lens exchange, including a pinhole IOL that's available in Europe, but not yet in the US. We have corneal inlays, which have lost their popularity. As far as the ones here, I didn't list the allogenic inlays, which I realized I should have, since Dr. Mrochen and Dr. Kilic are some of the pioneers in that area. So actually, there are some other ones that aren't listed. There's some scleral inserts to make the sclera more rigid to restore some flexibility of the lens. There's using a laser to the sclera to restore flexibility of the sclera. There's reduction of pupil size, which Dr. Agarwal has developed, which is the fourth row pupiloplasty, which is almost, again, like the eye drop. It makes the pupil really small, but it's permanent. And conductive keratoplasty was available in the past, but has dropped off. So there's a long list, and then there's non-surgical options, including spectacles, contact lenses, and now these drops for presbyopia. So there's really two categories. One is to make the pupil smaller. And there's multiple companies that are competing in this area to come out with their technologies. We have Allergan, Orasis, presbyopia therapies, and Visus. And the whole idea is that by making the pupil smaller, we get this enhanced range of vision. And you can see that in this picture, that you can see up close, but also distance, by making the pupil smaller. There's a second technology, which is try to make our natural crystal lens softer by breaking some of the bonds within the lens. So it's called lens softening technology, and we'll talk about that next. So the one company that I'm aware of that has this technology recently sold their technology to Novartis. Basically, it's this technology where it's an eye drop that goes on the eye. It's a prodrug. It basically gets broken down into some naturally occurring substances, and that can break the disulfide bonds that can restore the lens microfluidics. So basically, the lens is softened, and now the lens can flex more. And so it's basically, as Dr. Marshall just talked to us about rejuvenating the retina, we're talking about rejuvenating the lens here. So Dr. Marshall had a great, I guess, talk to prepare us for this concept with this technology, which is still a few years out, but very exciting. And then they had some data that they released that publicly, and this is showing that looking at the percent of subjects that gained vision at near, and you can see that over time, as they took these drops, they had more and more patients getting some improvement in their near vision. So we're looking forward to seeing how this works long term and whether this can really make a difference for our patients. Now, the 4 drops that have been developed, or 4 companies that are developing drops for presbyopia that are making the pupil smaller. There's multiple different technologies being used. One's called aceclidine, which is a company makes the pupil smaller with tropicamide. And the concept is that this combination makes the pupil very small, but the tropicamide helps prevent it not getting too small, and then again gives you this increased range of vision. So it's kind of a double a combination drop, but trying to just optimize the pupil size at a certain level to give this nice enhancement of our range of vision. So again, this is called PRX 100 by Liquid Vision. So we're excited to see this technology. It's in the phase 3 clinical trials, I believe, at this point. Orasis is the second company. This is the company that's developing their product. It's a low-dose pupillary miotic that, again, trying to give this range of vision. And what they've been working on is to make sure that their patients can get this near vision, but also not lose their night vision. If you make the pupil too small, then patients really complain about driving at nighttime. And so they've been working hard to try to optimize their drop for that, get that nice range of vision, but still work at nighttime overall. So a very promising technology. Again, still in the clinical trials overall. A third company, Visus, is developing this medication that they're calling Brimacol, which is a combination of brimonidine and carbachol. And basically, the 2 medications work synergistically to make the pupil smaller, but not too small. The carbachol makes, works on one part. It works on the sphincter contraction, and bromonidine helps prevent the iris dilator from contracting, so you get a nice pupil size. They're calling this Brimacol. So again, very promising. And they do feel that there's an impact on ciliary body, so you may avoid some of the headache and brow ache and myopic shifts that may occur with some myotics. Again, still early, but exciting. And the last company that's very exciting as well, and who I think they may be the farthest along, at least in the US, for getting approval, is Allergan. They have a very exciting technology. It's a myotic, just as we run through all these companies, again, it's a proprietary technology for the delivery device, their delivery technology, and again, making the pupil smaller to get this nice range of vision. So how this drop for presbyopia changed the life of patients. I know for me, I'm in my 50s, and for my patients in the 40s, we're excited to be able to use a nice drop that we could use, that we could reduce our need for reading glasses and get to experience what it's like before we commit to surgery. There are many surgical options, but surgery has some risks. So let's see how they work. And it may direct some patients going one direction for one type of surgery versus other patients may choose a different direction depending on how the drops work for them. And some patients may just prefer using the drops if it's easy, or some may say this is good, but I'd rather just have a permanent procedure. The key is that as far as how it's making a difference for our patients with drops for presbyopia is that our patients want something that's very safe with a low rate of ocular irritation and discomfort, no long-term side effects. They want it to be reversible, which this all works, and is long-lasting in the sense that the hope is that it's going to be once a day. Might be twice a day, but at least the goal is once a day for our patients. And what happens if we can deliver this? Well, as we get older, and when you start putting reading glasses on, it automatically ages you. You, by definition, are a little bit older because you need reading glasses. So it keeps us having the appearance of being youthful. We can use Botox and superficially look young, but when you wear glasses, it's a giveaway that you're not as young as others. So it helps keep us youthful. And we work with our coworkers, again, for our patients. Being young is it's desirable by many of our patients, and not appearing like that older. So not needing glasses at work could be quite helpful. So I think this is exciting technology. We're really excited for it to become available for our patients. It seems it'll be very easy to prescribe for our patients. We'll get a nice sense once we have it available to how it can help our patients. And I'm very excited and happy to answer any questions. Thank you very much.
Thank you.
Thank you so much, Bill. It was really very exciting technology. Actually, we can discuss details, but I just want to ask you very general questions to make it clear. We can use these drops both eye or one eye. And second question is, all refraction, what is the indication about refraction?
Okay, so if you make the drop is very effective on a patient, and probably by patient, and the pupil becomes too small, they'll feel they may not feel great with it. They may be able to read, but they may feel they have too much loss of their visual field. So you may only, that patient may only use it one eye. If you get miosis in both eyes to a good level that works for that particular patient, they may feel comfortable using in both eyes. So it'll probably be a patient by patient customization depending on their pupil size and how the drop affects them.
Yeah, of course. Okay. Yeah, what about refraction indication? Emmetropic patients, or you showed a nice keratoconus patient with astigmatism. Also, we can use keratoconus patients, and also myopic, hyperopic. How is the range?
Right. I mean, I think that's something we're going to learn. I mean, when you have a pinhole effect, you get definitely we do that all the time in our clinic. We know we can get an improved range of vision. So it'll be patient by patient and how it works for them. Obviously, if you're emmetropic, it's going to work better, but some myops or hyperopes may do okay, and we'll have to see for each patient.
Adnan?
Yeah.
Yes.
So you switch on your microphone.
Hi, great talk. Given I'm a myope who's now compensating by pushing his specs down the nose, I'm very excited about your talk. But just as some general points, people who want to avoid reading glasses who are emmetropic before do it partially because of social interaction issues, and a popular notion about being attracted to somebody is having a big pupil. Has that been come up with any patients, or is that an issue? You're a refractive surgeon, you've got to deal with these things.
So that's a great one, because younger patients have bigger pupils. You're absolutely right. So having a bigger pupil is a sign of youthfulness as well. So that's the first time someone's mentioned that, but I really appreciate that you're sharing that concept. Yeah, I don't have a good answer for that yet. I'm sure that will come up.
Could have cosmetic contact lenses with a big pupil on top of your myosed eye. How about that? I'm happy to go into business with you on that one.
I like that.
Well, guys,
I think the corollary of that that Adnan has just brought up is in London, if you get stopped by the police with small pupils, there may be quite significant consequences.
anyway, this is a problem mainly for people with blue eyes in whom you can actually see the people. And people with very deep brown eyes, I have trouble seeing their pupils. They'll love this drug.
Are you a Prof?
Yes, I am.
So in our field in refractive surgery, more than 50% patients visiting us to remove glasses, reading glasses, and they are always dreaming one laser and everything finished. They will see distance, they will see near, both same time. This is really big trouble for us. I refuse so many patients because of limitation of lasers or premium intraocular lens. I think this drop is very useful for future, because if people is ametropic, we cannot recommend surgery very comfortable. If we correct near, always distance vision sometimes affected. So multifocal lenses, especially, we cannot perform, and we want to remove glasses. Maybe as you are a refractive surgeon, your patients are very, I believe this drop, if it would be in the market, I would use this, not every day, sometimes even I can use myself, sometimes special days if I want to see clearly. This is really amazing technology. I am excited about that.
Bill, there's a question from the participants. How long do drops last? So are you putting in a drop and it lasts for a week, or do you have to drop every 2 hours, or what's the?
So my understanding is that most of the drops are working anywhere from 6 hours to 12 hours, depending on, well, and of course it's going to depend if they're blue-eyed, brown-eyed, and the effects, and what the optimal size is. But my understanding is that for some patients it's going to be once a day. Other people it might be twice a day, but I don't think it'll be more than twice a day.
And what is your experience in terms of patients, let's say, compliance in using the drops? So I can see in a study environment where they take the drops for a defined period of time, that's fine. But if you think about, this should be not lasting 5-10 years. Any experience of how the patient compliance in using the drops is?
Right. I mean, I think the compliance will be similar to remembering to bring your glasses. You either bring your glasses or you can't read. You either put the drops in, or you have to get glasses to read. I mean, otherwise, it depends on their life, what they're doing that day, right? So if someone's just going to be outside running, and they're like, or they're going hiking, maybe they don't feel like they need to put the drop in that day. So on what the patients are doing. But a great question. I don't know the answer.
I was fascinated by the drug that is, making the lens soft and young again.
Yes.
So I didn't really understand, to be honest, the mechanism, but is there any concern that will affect long-term other parts of the eye, like the retina? Are we creating more drusen?
Yes. Oh my gosh. I think that's a great question. EV06 was developed by a small company, and they sold it to Novartis, who is working on right now on getting it through the FDA approval process here in the United States. I did reach out to them to find out they're still under development, so I don't have a lot of details, and I don't know the full safety profile yet. So it's promising, but obviously with everything, there are pluses and minuses to everything. So we have to make sure that doesn't cause a problem.
At least it was reduce the retinal irradiance, Michael.
Okay.
Yes. also will protect retina from UV light with miosis. Exactly. This is also wonderful. Also may prevent from cataract.
It may make it difficult to laser through John.
He's going the infrared.
But you wanted to treat at 40 anyway, John. So we first treat with your laser and then we use the drops.
Wonderful.
Problem solved.
I think, I would like to thank again everyone for joining us. This was really insightful. Appreciate sharing with us your thoughts on what's coming next. It was wonderful. So thank you so much. Thank you for all the participants joining us tonight. And we're working on the next version somewhere in the next 6 weeks. But I really appreciate. Thank you very much, and have a wonderful evening. Thank you very much. Bye bye.
Thank you.
Bye.
Bye bye.